everyone. Thank you all for having us. It's great to be here at Horizons and see such a lovely, engaged audience. We're going to be talking a little bit about emerging indications for psychedelic therapies. Basically, there's been a preponderance of research. I'll start with my disclosures. It's great to follow up right after Elias's talk with these. These are companies that I am a paid advisor to. These are also companies that have paid for research that I do. But what is the state of the science with psychedelics, and what are we talking about when we're talking about emerging indications? We've got lots of studies, well, I don't want to say lots, but we have a good preponderance of data now showing antidepressant effects of 1 to 2 doses of psilocybin when we're giving people with major depression or treatment-resistant major depression that treatment. That's very promising and obviously is being developed further by a number of different groups. We also have multiple studies showing persistent reductions in anxiety and depression after 1 dose of psilocybin in patients with life-threatening illness like cancer. Again, very promising work. As we heard a little bit earlier, it's also being followed up on now with more severely ill populations. And then we have a good set of studies that are really indicating excellent potential for using psychedelics in treatment for substance use disorders. And we've looked at this now across a number of disorders, and that work is just growing by the day. So I think we have that as our baseline right now. But what next? I was talking to a fellow named Dr. Paul Rosenberg at Hopkins, who is a geriatric neuropsychiatrist. We were chatting about the possibility of doing a study, which we're now doing, in patients with early stage diagnosis of Alzheimer's disease or dementia. This is a huge problem. We got a very large number of people with Alzheimer's disease and related dementia right now. Those numbers are just going to multiply exponentially over the coming decades. And this has also been a real difficulty for drug development. We've seen over 240 failed drug candidates in the last couple of decades. These are all medications that have been developed and tested and not really shown to do much. Even drugs that have been recently approved, I would say, are dubious at best in terms of their safety and efficacy at this point. So, and we also know that there's a huge prevalence of psychiatric disturbances in folks who get these dementia diagnoses. More than 40% are going to have some sort of depressed mood. Obviously, it's depressing to have an illness like that or to get that diagnosis. And especially in the early term of this, in the first 3 months after a dementia diagnosis, you have more than double the risk of suicide. So, this is obviously a really big problem. It not only impacts the patient and their quality of life, but also the caregivers. And again, we know psilocybin has demonstrated antidepressant effects. I won't go too deeply into this because of time limitations, but there's been a great, robust literature looking at serotonin 2A agonist drugs in memory and cognition in animal models. And we have seen things like enhanced neuroplasticity, enhanced learning paradigms after administration of serotonin 2A agonists. So these also speak to a potential for improving cognitive function in folks who are experiencing these dementias. So, here's some of those data on neuroplasticity. We're doing a small open label pilot study, 20 people with depressed mood and a diagnosis of mild cognitive impairment or early stage Alzheimer's. It's an 8-week study treatment where we're administering 2 doses of psilocybin with supportive care before and after. We're looking at depression and quality of life as our main outcomes, but we're also looking at things like anxiety, memory function, and caregiver quality of life as well to just get a bigger picture of if this is worth following up in a larger randomized control trial. We just dosed our 4th participant 2 days ago, and we're continuing to enroll more people as we go. And so that's, this is a study that I'm very excited about, and I think, the potential for using psychedelics in neurodegenerative conditions is one that is just starting to be studied and needs to be expanded further. Briefly, I'll just also talk about another study that I started just a few months ago, actually, with my colleague, Dr. John Outcott at the Johns Hopkins Lyme Research Center. And Lyme disease is one of the most common vector-borne illnesses in the US. And we get about 10% or more of the patients who are treated for Lyme disease develop persisting symptoms This has been likened to something like long COVID, where you continue to have things like fatigue, pain, depression, and memory impairment and sleep disturbance long after you're supposedly over the infection. Some studies have likened or have linked some of these chronic Lyme-related effects, specifically to things like neuroinflammation. This is from our group at Hopkins, who did a PET imaging study with these folks and showing versus controls, there's a severe neuroinflammation as shown in the PET imaging here. We also know psychedelics have anti-inflammatory effects, antidepressant effects, and so we're doing another very similar study now, pilot study with 20 patients with a Lyme diagnosis, a chronic Lyme diagnosis, and they're getting the same sort of 8-week study treatment with 15 and 25 milligrams psilocybin. We're doing follow-up assessments afterwards to see how they're doing, and looking at the effects on pain, fatigue, sleep, and mood to check out if this has any benefits in terms of quality of life or symptom reduction. I have other studies in planning for looking at psilocybin for cannabis use disorder as well. I'm not going to jump into the weeds with this because of time limitations, but I've been very interested in addictions with psychedelics, and I think they have a lot of promise in that direction. And so we have a small pilot study that we're planning in that domain that we hope to get started early next year, I suppose. But I'll go ahead and hand it off to my colleague, Dr. NAYAK.
Thanks, Al. So I'm going to be talking about two future directions. First is psilocybin for opioid use disorder. The rationale for this is one, it's being studied for other substance use disorders. There's not a good reason to think this would be drug specific if this works. Two, I mean, I feel like I hardly need to justify the dire need for new treatments for this condition. But three, there is a precedent with LSD. Here is a study from the 70s that shows that a year after LSD treatment, roughly 30% of participants are abstinent from opiates versus something like 5% of controls. So we have a study that I hope to launch early next year. What are we going to be doing? Basically, people that have active opioid use disorder, not in treatment, so in Baltimore that's going to mostly be fentanyl, are going to be brought into an inpatient unit for about a week. They will get good quality standard treatment and be put on buprenorphine, which is an opioid medication that's used to treat OUD, but is used to reduce cravings, withdrawals, also prevents overdose deaths. So everyone will get good quality standard treatment, but half will be randomized to 30 milligrams of psilocybin, which is a very high dose, versus placebo. So it's a good real-world design. People will be followed up at a month. The outcome will be a measure of abstinence encompassing self-report and urine toxicology. We're, of course, going to look at all kinds of other outcomes, including mood, well-being, pain, and other drugs. And we're planning to recruit 50 people, but it's a Bayesian sequential design, which means that we can stop early for clear evidence of utility or futility. But if there's indeterminate evidence one way or another, we can actually continue to accrue participants. So this is a graphical depiction. So people are going to come in. They will have their week-long induction on buprenorphine. During that time, they will be getting preparatory sessions, psilocybin, discharge, and then they'll continue to get outpatient buprenorphine and attend integration sessions and other study measures. At 1 month, the primary outcome is collected, and people are referred out to the community and followed up at long term. And I think that a lot of psilocybin studies there's a problem with diversity. These are actually quite difficult for people to attend. They often end up attracting well-to-do people with very flexible jobs, but I think that this study is quite likely to attract and retain a much more diverse population. I'm not actually going to get into this, but the point I want to make is that the inpatient procedure is not something I made up. It's not at all novel. I'm just copying something that is already being done in existing non-psilocybin opioid studies. So there's some reason to think that this will work out. Okay, so anorexia. This I will actually spend a little more time describing background. So this affects up to 4% of females. It's increasing. It is the highest mortality of any psychiatric disorder, roughly 5 to 6 times higher than the general population. About a fifth of that is suicide. The rest is like medical complications of anorexia. And comorbidity is very common. anxiety disorders, mood disorders, personality disorders, as well as PTSD, substance use. Treatment outcomes are not great, but it is a behavioral disorder, and in that sense shares some similarities with substance use disorders. It's quite challenging to treat, not least because these patients often are struggling with quite a lot of ambivalence. They want to get better, they don't want to get better. Cognitive rigidity, tendencies to perfectionism control are much higher in this population, and this manifests in the psilocybin experience in certain ways. I've already mentioned the comorbidity. So this is a study that has just recruited the final and 18th participant. It's led by Nathalie Gukasian at Hopkins, taking people with anorexia that can be in partial remission. They've had at least one prior treatment attempt, illness duration 3 years. And normal BMI is like 18.5 to 25, where our average is like 17.8. And it is an open label pilot study. People are going to get standard preparatory sessions. There's nutritional guidance available, but it's quite non-directive in the approach, which is distinct from typical anorexia treatment approaches. People get up to 4 sessions, 20 to 30 milligrams. Time is up. Anyway, primary outcomes are safety, mood and anxiety, and quality of life, but we are looking at secondary outcomes of BMI and eating disorder severity. Hopefully we will know the results in a few months. We're hiring. Do we stay up? We stay up here.
Yeah, if you two could stay up here, once the full panel has spoken, we're going to do a quick Q&A. I'm going to do an abbreviated bio for Dr. Emmanuelle Schindler, who's an MD, PhD. She is a neurologist and headache specialist at the Yale School of Medicine, and she is also medical director of the Headache Center of Excellence at the VA in Connecticut. Please welcome Dr. Schindler.
Thank you so much. I used to give psychedelics to rabbits, but I never got to speak in front of such a large crowd until I gave it to humans, so I'm in the right, I think I picked the right path. So I'm going to talk about a couple of my studies, my disclosures here that are relevant to the research I'll talk about. First off, what is a headache disorder? These are common neurological disorders characterized by paroxysms of pain in the head, but it can also be in the face or the neck. There are various parts of the brain that have been identified to be relevant in headache disorders, and not just central, but also peripheral nervous system as well. And there are dozens of different headache disorders. Most people have heard of migraine or tension-type headache, but there are dozens of different types, and they're classified by their characteristic headache attacks, which involves the location, the pain intensity, duration, frequency, and some other factors. So for decades now, and you can even go back and find more evidence from hundreds of years ago, there have been reports of psychedelics having therapeutic effects in headache disorders. Most of these reports are in cluster headache. Cluster headache is a rare headache disorder that is the most painful pain condition that has been rated. And for that reason, it's also known as suicide headache. And we have a couple cluster heads in the audience who would be thrilled to talk about their disorder, because it's not very well known. There's not enough funding to study it, and there aren't very many treatments that are available and effective. So cluster headache patients have sought out different treatments, and it was actually by accident that they found out that psychedelics have a very interesting effect on their disorder. And I'll show that here. The majority of cluster headache patients have their headaches for a certain time every year, for weeks or months at a time. So here's a cluster headache patient's diary where he's putting out every day of his cycle, which is about 2 months long, his headaches. And the vertical axis there is the time of day. And as you see, his headaches all tend to cluster around the same time of day. That's part of where the name comes from. And so when the cycle starts, the headaches are less severe severe, that's the blues and greens, and as the cycle continues, they get more severe and more frequent, and then it tapers off. So this person had cycles every 2 years, so when his next cycle happened, his headaches ramped up, and he'd heard about psychedelics. He took a low dose of psilocybin mushrooms, and immediately, for several days, had fewer attacks, less intense attacks. He took a large dose after the headaches got a little bit worse, and the cycle ended. So 2 doses, a lower dose and a higher dose, ended the cycle. There's nothing in headache medicine that can do that you can take once or twice and completely terminate a cycle. So this is very unique in terms of headache management. But it's not surprising that psychedelics would have effects in headache disorders. Just looking at the chemical structures of different headache medicines we currently use. So next to psilocybin, melatonin and sumatriptan, they both have the indole ring. They're indolamines. And if you twist the LSD a little bit, you can see it lines up really well with methysergide and DHE, which are also headache medicines. DHE is taken off the market because when taken as a preventive, which is how it was taken, it caused fibrosis of various tissues, which is understood to be an effect of targeting the serotonin 2B receptor. So there are a lot of anecdotal reports and self-reports and surveys, but there were no clinical trials. So with the help of Bob Wold, who's pictured there, sponsors and other, and some mentors, I jumped on board to an already developing program to study psychedelics in headache disorders. I will talk briefly about a migraine pilot study that was published a couple years ago, or last year, and then a cluster pilot study, the first part of which is in press right now, and then there's a second part where I had patients come back for a second round. The migraine study is both are very preliminary studies. They're both double-blind, placebo-controlled. And the cluster study, it was randomized. The migraine, it was a crossover study. The main outcomes would be a reduction in the headache burden, so number of headache days per week, and then we also looked at other measures as well. So these were the results from the migraine study. So in this study, all patients got a dose of the placebo and then a dose of the psilocybin, which was 10 milligrams. So in the 2 weeks after placebo, there was basically no change in their headache diary in terms of how many migraines per week there were. But in the 2 weeks after psilocybin, there was a reduction by about half, and that's the first graph there on the left. The pain intensity of those migraines that they had was also reduced by a little bit. The duration was also reduced, but not different from the placebo, but still there was an effect there. For the cluster headache study, this one is the first part, as I mentioned, is in press right now. The second part is wrapping up. But here I just show a couple examples of some patients who took part in the study twice. So in the first, on the left, this is a patient like the one that I showed you before who has cycles once a year. And so when they received placebo, their headache frequency went down over the 2 months. But when they came back for their next cycle and got psilocybin, it went down much faster, and it actually ended. And then here's another example on the right. This is a chronic patient. So chronic cluster headache patients have headaches all year round. They don't get a break, so they're really hard to manage. This person happened to be randomized to get the psilocybin twice. So the first round went down a little bit, maybe a 30% reduction, and then back up, and then over the 2 months, not much difference really. But then when they came back for the second round, there was a dramatic reduction by about 75%, and it stayed there for the whole 2 months. And this is, again, after limited exposure to the drug in the beginning and then a long-term effect. What was also noted was that the intensity of the psychedelic experience during the test day did not correlate with how much of a reduction in headache burden they had in the for migraine 2 weeks, and for cluster 2 months time. And when you step back and look, it almost looks like people who had a smaller psychedelic experience had a greater reduction. But these are, of course, small numbers, and so we can't really say much, just that there was no association. And this is a little bit different from what you may hear in terms of the psychedelic experience being central or being part of the treatment. For headache, that does not seem to be the case. And then for these studies, I put the adverse events together from both migraine and from cluster. Not unexpected. Some nausea, anxiety, and lightheadedness were most common during sessions. They were all very minor, and they self-resolved. I always get the question, don't psychedelics cause headaches? I say, yes, it causes one headache, but then you have reduced headaches for weeks or months, so it's worth it. So yes, we did have patients who had headaches either the day of or the day after, but that's not unexpected. So there's a lot more work to do. All these findings are exciting, and they support the decades of patient reports of the long-lasting effect of these drugs. There's much more work to be done. We need larger samples, look at varying doses, looking out over a longer term, and you can see all the things listed. To the right, I have all of the active or in preparation headache studies going on. The two I just mentioned are the ones on the top. There's a Danish study that also completed, and I had to update this slide because the LSD mini dose, one at the bottom there, was just listed. It's in preparation as well. So this area of research, it's been recognized, and we're going forward with it. So it's very exciting. And I'll be happy afterwards to answer any questions.
Thank you very much, Dr. Schindler. And our last panelist for emerging indications is Dr. Christopher Pittenger, who is a Mears and Jameson Professor of Psychiatry, Deputy Chair for Translational Research in the Department of Psychiatry, and Director of the Yale Program for Psychedelic Science.
Thank you. It's an enormous pleasure to be here to speak to you today. I have a few disclosures here, but the most important disclosure is that the work that I'm going to tell you about is really pushed by my colleague, Ben Kelmendi, who is here with us today. So I have the pleasure of sharing it with you, but I want to acknowledge Ben as a partner and an engine in everything we do. So I'm going to talk to you today about OCD. And in one sense, what I'm going to tell you is just another disorder, right? We're trying psilocybin in another disorder, and we have promising evidence, right? And that's my talk right there. But I want to spend a little bit of time thinking about OCD and why it's a little different. Because a lot of the conditions in which psilocybin has the strongest evidence for benefit, and you've heard about some of them here, of course, the published work in depression, in end-of-life distress, and in addictive disorders. It makes a certain amount of intuitive sense that a psychedelic experience which changes one's relationship to meaning or one's relationship to, one's sense of self would have an effect in those disorders, most obviously perhaps at the end of life despair. But I think there's an intuition there that's shared across the disorders. And that's less intuitive in OCD. Let me tell you why. I suspect that psilocybin is much more familiar to this audience than OCD. And so I'm going to invest, even though I only have a few minutes here, I'm going to invest a couple of them in describing a little bit about OCD. So OCD, as the name implies, is characterized by obsessions and compulsions, right? You don't actually have to have both in order to get the diagnosis, according to the DSM, which is our current guidebook, but almost everyone has both. So the characteristics of obsessions and compulsions and the relationship between them are illustrated on this slide. Obsessions are thoughts that come into the mind unbidden, they feel foreign in some way, and they're unpleasant. They're not necessarily irrational. So an obsession like, I might be contaminated, I should wash my hands or I might get people sick, that's not remotely irrational, especially in the last few years. But in someone with OCD, it's extremely powerful. Okay? It feels very relevant, it feels very urgent, it cannot be ignored. Even beyond the case where a rational person would say, okay, yeah, I washed my hands, I'm good, an obsession won't necessarily go away. So they tend to be intrusive, inflexible, associated with anxiety or discomfort. If it didn't make you feel bad, it wouldn't be an obsession. Ego dystonic is just sort of a Freudian word that means it feels foreign. It doesn't feel like part of the normal run of consciousness. And they're excessive or irrational, as I said. The compulsions are the actions that people take in order to neutralize their obsession. So in the case of an obsessional thought about contamination, the associated compulsion, the logical one, would be hand washing. There are others that one might do. And it's not all hand washing. It's about 30% of patients with OCD. It's just an illustration. And the relationship between the obsessions and compulsions is illustrated in the diagram there. So in intrusive cognition, we all get these, right? We also all get thoughts that come into our head that feel a little uncomfortable and we kind of wish we didn't have them. And the question is, what do we do with them? The maladaptive interpretation is treating that thought as powerful or important. That leads to anxiety, that leads to the compulsion, like the hand washing. That makes you feel a little better. So far, so good, right? The problem is that the fact that the compulsion actually worked and actually made you feel a little better leads to, reinforces the interpretation that actually was important, right? Good thing I did that, right? And that leads to a feedback loop. And so that's what OCD is, at least as I formulated it. It's being stuck in this feedback loop between intrusive thoughts and compensatory behaviors. And in psychotherapy for OCD, there's very robust cognitive behavioral therapy for OCD. It's called symptom evocation and response prevention, or ERP. And the goal is to interrupt this loop. And what you do is you induce an obsession, and then people experience their anxiety, but you don't let them do their compulsion. This is very difficult. It's hard work, especially for the patient, but also for the therapist, to go through this, because it requires a lot of distress tolerance. But over time, you interrupt this cycle, and you rob the thoughts of their power. The reason I go into this, other than just to put us on the same page with respect to the diagnosis, is to emphasize that the interruption of this loop isn't the same thing as gaining meaning in your life, or some of the sort of the intuitive things about what psychedelics may do. At least it's not obviously so to me. OCD is a big deal. It's less diagnosed than depression, substance abuse, schizophrenia, but it affects 1 person in 40 over the course of a lifetime. Of the DSM-4 anxiety disorders, it's the one that's most commonly severe. It was listed by the World Health Organization as one of the top 10 causes of disability, not necessarily mortality, but of morbidity in developed nations. And I list these facts just because it tends to be underdiagnosed, underrecognized, and poorly treated. So I think it's not widely appreciated what an enormous source of disability and suffering it is. We have treatments, cognitive behavioral therapy, antidepressants. They work 50-60% of the time. We can help a lot of people. There's a huge number, millions, who even if they get the best treatments available, they continue to suffer. And for that reason, we're desperately searching for new treatments. And I came into the psychedelic space as an outsider, looking for new ways to help my patients, and intrigued by some of these reports here. They're anecdotes in the literature. A few published. The first is going back to 1987. That's the earliest anecdote in the scientific literature. I've been able to find many anecdotes in the non-scientific literature and on the internet. Single study back in 2006 shown there, where they gave folks with OCD psilocybin, but they only followed them for about 24 hours. They tried a bunch of doses. They got similar response from all doses. It showed safety, certainly. It showed that you could give psilocybin to people with OCD, but it was difficult to draw much from it. So in this context, my colleague Ben Kelmendi came and said, we got to do a trial. We've got to see if psilocybin works. And so we initiated some years ago the first placebo-controlled trial of psilocybin in OCD. And I want to acknowledge all the points that were made earlier when I use the phrase placebo-controlled. Placebo-controlled in a psilocybin trial is kind of a joke, right? Everyone knows who got what. So we try. We give niacin, which is a standard but wildly imperfect placebo in the field. Expectation bias is a huge problem. People coming to this trial believe in it. They believe they're going to get better. They're highly motivated. They're not a random sampling of the OCD patients in the world. All of these things contaminate the study, and I want to acknowledge that right here. But this is where we start, right? Got to start somewhere. These are the vital statistics of our trial, the age range. The Y box, the Yale-Brown Obsessive-compulsive scale, developed at the clinic that I lead, but when I was about 12, so I take no credit. But that's sort of the gold standard measurement for the severity of OCD symptoms. 18 is kind of the bottom of severe symptoms. 40 is the maximum on this scale. We bring our patients to an inpatient setting. That's for monitoring, not really safety, but we monitor them quite closely. And there's other details there. Our primary outcome in this study was just at 48 hours. We did that because we wanted to get an effect that was as uncontaminated as possible by subsequent interactions, therapeutic interactions or support. But we followed people for 12 weeks. This is just a visual depiction of the course of the study. Primary outcome at 48 hours, but we follow for 12 weeks. We're collecting a lot of other data. We're collecting narratives and doing qualitative analysis to try to understand people's experiences. We're doing some fMRIs. There's a lot in here. This study is ongoing. It was interrupted by the pandemic, but we are unblinding as we go. We're not keeping everyone blinded. Because of that, I'm able to show you data. And these are sorry. We're doing this very much on the Hopkins model and the Bill Richards model, comfortable room to attendance. Because of time, I'm going to jump through and get to the data. These are our completers before the pandemic, okay? We got a lot more than this now, but the data that I've been showing is just the people who completed before the pandemic. 9 people. Y-box on the y-axis, down is good. Dotted lines are niacin, nobody got better. Placebo response is very low in psilocybin in general. Among the people who got psilocybin, 2 of them remitted completely at 24 hours. I have never seen this before in my career treating refractory OCD. A third one got 50% better, and we had 2 non-responders, 50%. 12-week data. If you got better at 48 hours, you stayed better for 12 weeks, okay? And again, this is 5 people. This is a handful of anecdotes. I don't want to oversell it, but I've been treating refractory OCD for 20 years, and I've never seen this before. The people who got niacin had the opportunity to cross over and get open-label psilocybin. 3 of them did. We had another good responder with an over 50% response, a brief responder, and a non-responder. So about 50%. Okay. This is ongoing. In another year, we'll be completed. Our N is we're aiming for 30, and we'll analyze our data, and we'll do statistics, and we'll do all that stuff. But we're pretty excited about this. Because of time, I'm going to have to stop. But I just want to I started by saying how OCD feels a little different, and the way people respond to CBT and OCD is different from the way people respond in depression or end-of-life despair. But what people tell us isn't the same thing they tell us when they respond to CBT or SSRIs. That thing's blinking at me, so I got to talk fast. But they're not telling us my obsessions are weaker and I can ignore them. They're telling us I still have them, they just don't matter. So I think the idea that there has been some kind of recalibration of their sense of meaning or their relationship between the self and the content of their thoughts may be the way to conceptualize this, not just as another way to do the same thing that our other therapies or treatments do. But that's speculation from anecdote, so stay tuned, and we'll hopefully develop more insight over time.
Thank you very much,
Thank you.
Dr.
Carried away with the
Pittenger.
beginning part.
Just reminding you all to
That's the important stuff.
go to Slido, press the Ask button, scan your QR code, ask questions, upvote questions. The most popular question here is there any indication that psychedelic-assisted therapies might be effective for personality disorders? I understand none of you spoke of that. Do any of you feel comfortable opining on that?
The short answer is I don't know. However, I will point out that there was a depression study, treatment-resistant depression with ayahuasca. The majority of those participants did have various personality disorders. That's the only one as far as I'm aware. And they had fairly good effect.
Second question is, why has there been an increase in research on the effects of psilocybin and not LSD? I kind of have my own assumption, which is simply that it's too long a day for everyone involved. But if anyone else would like to take a stab at why that may be.
Yeah, I think that's true, that LSD is longer. It's also a dirtier drug, meaning it does more things in the brain. So the neurobiologist in me likes psilocybin better because it's a little cleaner. I also think LSD has more cultural baggage.
Yes, that's also true. Does anybody want to hazard a guess or discuss mechanisms of action, what we think may be going on? We really haven't talked about mechanisms of action at all today.
Well, for a cluster headache, the hypothalamus has been identified as a central, no pun intended, it's a key component for the disorder. So there are groups looking at the hypothalamus and whether there are changes after treatment.
Someone was asking about atypical migraines, wondering if this specifically asked about migraines in the GI system, in the stomach, which I have to admit I'm not familiar with. But
yeah, so for our studies, we do stick with the typical migraine diagnosis because there are many different types of migraine: hemiplegic migraine, menstrual migraine. In kids, there's a GI form, and so we wanted to first stick with the quote-unquote clean population of standard migraine. Theoretically, it may still have an effect, but because there are a lot of GI effects with the treatment, it may not be a very pleasant treatment if someone has a majority of their symptoms in their GI tract. But one day of unpleasantness might be worth it if it provides long-term relief.
this question is for the Hopkins team. Do patients with substance use disorders require higher doses of psilocybin for psychedelic experience or efficacy in these trials?
I think that's the lore. I don't know if my mic is on. Can you hear me?
I don't think your mic is on.
You want to go ahead and?
That's the lore?
Yeah.
Are you saying that it's just like folklore or something?
Well, I mean, this is like what Bill Richards and some of the early researchers observed clinically, was that many patients that were being treated with substance use disorders seemed to require higher doses. At least that's how I understand it. But, cleverly, like Michael Bogenschutz, who's up here earlier, Matt Johnson, who I work with, and others, have kind of built that into the design of a lot of our treatment trials, where we will start off with what's a fairly high dose, with, for instance, 25 milligrams, and then if folks don't respond to that, if they don't really have a strong subjective drug effect, then we're able to go up higher to something like 40 milligrams, which is what Bogenschutz did in his study. And so I think that that's a really effective way of doing this type of thing, so that we can tailor it to individual treatment response.
Great, thanks. Dr. Pittenger, this one's for you. Any chance that if psychedelics help people with OCD, they may also be helpful with tics and Tourette's?
Really interesting question. So Tourette's is quite common with OCD. Like 40% of kids with Tourette's develop OCD, and 10 or 20% of people with OCD have tics. We have no data to speak to that. Tics often get better in adults, and we're treating adults. So we had not had any patients who have severe tics.
Right, I mean, all of you are treating adults. Do any of you have any plans to treat younger adults or adolescents?
We're pushing our study. It was originally 21. We're pushing down to 18, not yet below, but certainly in the medium term, that's something that I think is hugely important.
Great. What else do we have here? Dr. Schindler, how does psilocybin's effectiveness for treating headaches compare to other headache medications?
Great question. So in the pilot study, there was a reduction by about half. So patients started out with about 3 migraine days a week, and they were down to 1.6 or so. That's roughly on par with the other migraine preventives, but other migraine preventives, you have to take them every day. Whereas psilocybin, it's one treatment. Even the newer CGRP targeting monoclonal antibodies, it's a once-a-month shot, but the medication stays in your body the whole month. So psilocybin offers a really unique mechanism. Yeah.
Dr. Pittenger, I had a question. I just have to find it. Sorry, they keep shifting around here because as they get upvoted, I lose them. Yeah, looking at the responders versus non-responders, any chance you're going to look at genetics or just try to figure out what's going on? And also, I would like you to talk about the interactions of the SSRIs with the psychedelics, because I imagine a lot of your OCD patients are on SSRIs. Do they taper off? Do they stay on?
Yeah, so second question first. We require people to be off SSRIs for the same reason that everyone does. It can make things simpler. We do speculate that the SSRI causes a downregulation of the 2A receptor, which may reduce the psychedelic effect. In fact, one of our non-responders had come off very, very early in the study, had come off her SSRI only 2 weeks before. We were doing the 5 half-lives thing, and that's not sufficient if there's a brain, you don't just have to wait for the drug to get out, you have to wait for the brain to re-equilibrate. So we now require 8 weeks. So all of these patients are off SSRIs, and that will be a complication to deployment more generally. I forgot what your first question was.
If you're going to maybe parse out why the non-responders might be non-responders, what would you look at?
Well, so the 2 people in the original 5 who were randomized to psilocybin who didn't respond, one of those was that SSRI case, and she had no psychedelic effect at all. So that's a hypothesis. The other one had very strong obsessive-compulsive personality disorder comorbid with the OCD, very rigid character structure, and was, during the dosing session, was actively resisting having the experience.
How does one actively resist the psychedelic?
I don't know, but he was pretty good at it. Wow, this is interesting. I can see that something is happening, right? So.
Very intellectualizing.
Yeah, and so I speculate that that sort of rigid control may have gotten in the way of his ability to benefit, but this is speculation based on anecdote. So, but it's certainly something we're going to be looking at. The N won't be anywhere close to enough for genetics, but we will be looking at neuroimaging, and maybe there'll be some qualitative hint at the effect in the neuroimaging. It's certainly something we'll look for.
So are you looking at fMRI or PET scans? Or
we're doing resting state fMRI before and after, not during, because we don't want to disrupt the clinical experience, but before and after.
And also, Dr. Schindler, there was no psychotherapy with your patients, correct?
No,
Right.
no.
Okay, I think it's worth underlining this 5 half-lives is clearly not enough for coming off of SSRIs
Yep.
before psilocybin, in case anybody thought it was. I am going to thank you all and dismiss you, but ask you to come back at the end. Don't forget, we're going to be having like the grand Q&A. If you have questions that didn't get answered, you will have a chance to resubmit them through Slido at the end. Thank you all for a great panel.
Thank you.
Thank you.